This is a program under Lucy's children. Lucy, being the Australopithecus that was founded in 1974, which at the time was the oldest fossil in the evolutionary chain, uh, the human evolutionary chain, I should say. Lucy was not quite human and she was not quite an ape, over 3 million years old. So we named ourselves after Lucy with the understanding that we're all actually connected. There's really only one family, it's the human family. But some of us are very slow to understand that and appreciate it. Having said all that, what we do from time to time is give presentations. Some of them are done by our members, and some of them are done by guest speakers. Tonight, we have a guest speaker. We have Dr. Robert Fullilove, who is a personal associate of mine. I've known him for many decades. He's a very dedicated public, I guess I could call him a public servant. He's a professor at the Mellman School of Public Health at Columbia University. And an interesting fella. He goes all around the world. He meddles in all kinds of medical issues. One of them that pricks his interest is pandemics and epidemics. And one of the things that, of course, we're going to talk about tonight is the condition of the American society and wherever else he wants to go in terms of his conversation, in terms of preparation. Because as you know, the esteemed leadership that we have in Washington, D.C., has seen fit to cut us off from known networks of experts in other parts of the world who are simultaneously working on various outbreaks of communicable situations that we all need to be aware of. And in one of our earlier notices, was remembering for you how this country was in COVID-19. People will have a very short memory, but I remember the fear and how the country was afraid. The streets of New York were empty. People didn't know which way to go. And the leadership that we had didn't know which way to go either. That's the bottom line on that. So, having said all of that by way of introduction, I would like to introduce to you Dr. Robert Fullilove, who is going to take us on a medical public health journey. He's going to talk about whatever he wants to talk about, and he's going to give us the benefit of his brilliance. So, thank you and welcome, Dr. Fullilove.
Thank you very much. I can't tell you how much I appreciate that introduction. And for those of you who might wonder how it is that Muriel and I know each other, we are both veterans of Mississippi Freedom Summer. So this is the 62nd year that we have been involved in something that many of my students at Columbia have forgotten. In fact, they didn't even know it existed. But as someone who's got a very strong connection to the past, let me begin by saying a few things about why I am in particular fascinated by pandemics and why, as someone who is heavily involved with the struggles against COVID-19, particularly in New York State prisons, I want to sort of bring the past and the present together. First, just a word about me before I go to a couple of PowerPoint slides. Forgive me, I am a Columbia professor, and when we do Zoom, if you don't have PowerPoint, people are wondering whether or not you've forgotten something important. But before I get to that, I want to give you some background information about why, in particular, this topic is of special interest to me and why I think engaging people in a conversation about what comes next, because I do believe we will, as a nation, be facing another pandemic in the near future. Everything that we know about the science of pandemic ultimately comes down to if the CDC and the WHO are not present to help us coordinate what we do, what might folk in groups like the ones here tonight do to make sure that in a moment of public health crisis, we're in a position to respond? First and foremost, I'm from a family of physicians. My grandfather Dr. Robert Fullilove Sr., was born in Tupelo, Mississippi in 1834. He graduated from Meharry Medical College in 1907, practiced medicine for 52 years in Yazoo City, Mississippi, and here's the key, was one of the physicians in the state of Mississippi in 1918 treating Spanish flu. Spanish flu, I'm hoping people recall, was probably our first and most significant viral pandemic of modern times. Estimates are that it killed somewhere between 40 and 60 million people. And one of the people it killed was my grandmother. The idea that in a state like Mississippi, highly segregated, access to medical care was really quite restricted. My first family engagement with the pandemic started with the fact that because my grandfather was probably not able to save my grandmother, my dad became a physician in 1934 when he graduated from Howard Medical College and practiced medicine in New Orleans, where I was born in 1944, and in Newark, New Jersey, where at the end of his life in 1986, he was the president emeritus of the North Jersey Medical Society. My father, with the last name Fullilove, ironically, was someone whose medical practice was heavily concerned with sexually transmitted diseases. There's a film, The Invisible Shield, where I actually talk about what it's like to do work in public health around pandemics, especially HIV/AIDS, where for me, entree into that struggle was made all the more dramatic by the fact that I was the second generation of folk with the last name Fullilove, engaged in our nation's battle against sexually transmitted diseases. In 1986, with Mindy Thompson Fullilove, my ex-wife, but someone with whom I'm still working, we began a career that started with the establishment of something called the Center for AIDS Prevention Studies. So the second viral pandemic of our modern age, HIV/AIDS, was something that I started to become involved with at a moment when it was clear that this particular virus was going to have a dramatic impact on poor communities, and most especially poor communities of color. In the 40 years I've been engaged with work around public health and HIV, because it is still with us, I've seen a great deal. In 1999, I chaired the Federal Advisory Committee to the Centers for Disease Control on HIV and sexually transmitted disease prevention and treatment. And for 5 years, I was part of a committee that had advisory capacity over the $32 billion a year we spent on that viral pandemic and its impact on life in the United States. Part of the time I started working with HIV with the CDC put me in connection with Anthony Fauci. As the head of the USAID, the part of NIH that's concerned with allergies and infectious diseases, I was part of an ethics committee that was very concerned with the production of HIV meds. We finally had some medicines to treat this virus in 1996, at a moment when we were trying to prevent the transmission of HIV to infants and children. Some of you might recall that at the worst point of the pandemic, women who were infected with HIV would often give birth to a baby who was HIV infected. And before we had meds, that almost routinely resulted in the baby's death before the age. Well, at the moment we actually had medications, the question became, if the parents are no longer alive, how do we ethically assure that access to these medications and using young children in clinical trials is ethically okay? So this is a way of saying that I not only had an opportunity to work for a 10-year period with Anthony Fauci in the year 2020, when COVID-19 showed up, I was part of a advisory committee that was intended to help Fauci and others at the National Institutes of Health and the Centers for Disease Control understand what we'd have to do to produce a vaccine for COVID-19 that would be tested on all the communities in the United States, so that when the rollout of the vaccine occurred, people would be assured that the vaccine they were getting had been tested on folks like them. That's 3 viral pandemics I've been involved with. either as a member of a family of physicians heavily involved, and the fact that I've been at Columbia University in the Mailman School of Public Health, I'm in my 37th year, has meant that I've not only had an opportunity to do some of the work that we put forward in public health to combat public health crises, I've also been involved in training a very large number of physicians and public health professionals who have been deployed to communities where the battle against infectious diseases is ongoing. Now, what I want to point out is that we are at a very different point in history. Those of you who are here tonight because you saw Muriel's quite excellent email about what's happening in Washington really requires something in the way of an introduction before I get to my slides. Why did the Trump administration have such a successful bout of essentially tearing down a significant portion of the infrastructure that runs the public health enterprise in the United States? I want to be clear about why I'm so happy to speak with all of you. I think the science of public health is done great at the moment when the epidemiology of illness, disease, and epidemics was being studied. What we're at is talking to the general public. When Trump came on board, he said, look at the billions of dollars we've been investing in the public health infrastructure of the United States. We have a nation. Now, remember, this isn't Trump speaking. I don't know that he's capable of that level of speech. I'm really sort of rounding out the arguments that were used at that time from the Heritage Foundation's 2025, which is the real architect for the stuff we're going through right now. That body of information pointed out something very important. Since 1983, we as a nation have been struggling with issues of obesity and overweight. You might have noted Muriel's email that pointed out that 74% of adults in the United States are of their weight. They're either overweight or obese. 50% of African American women in the United States aren't just overweight, they are obese. The point was made that if we've been battling obesity since 1983, every single year, we get numbers that suggest we're getting larger as a nation and struggling with the most important risk factor for chronic disease in the United States, literally being overweight, and struggling with all the issues that are associated with diet, lack of activity, all the things that obesity represents. So it's not just a health condition, it's a way of sort of representing all those factors in American life that are leading to very poor levels of health. Well, he points out we've been investing billions of dollars for more than 40 years and we have no results. What's the return on the investment? If every year the American public has a larger waistline, aren't we wasting money? And maybe we should be investing in something else other than the kind of public health that the CDC has put together. Second point, since 2016, the life expectancy of the American public has been going down. We're dying younger and younger and younger and have been for a while. There's been a slight reverse over the course of the last year, year and a half. But the point was made, if we're making such a large investment in public health, but every year life expectancy gets worse, doesn't that suggest that the investment we're making in public health is really not returning what it should on the investment? And to the degree that the American public has always struggled to understand what exactly is public health, what is it that those folk do? If you add to that the very large levels of dissatisfaction that are associated with our management of COVID-19, you had the perfect stage upon which to have a change in the administration in Washington be provided with a flat platform that would essentially say, the dollars we're investing in public health don't work. Let's find something else to do with it. And the problem is, at the end of a pandemic, what we needed to do was think about, oh my God, what do we do to make sure this doesn't happen again? But maybe you, like me, are kind of clear. We've almost forgotten that COVID-19 occurred. We're so much about a nation that wants to forget it ever happened that instead of focusing time and energy and attention on making sure that that horrific past doesn't repeat itself in the future, we've instead chosen to look off to do other kinds of things. With that as a backdrop, let me say some things about what we know about pandemics and the ways in which everything that we're doing at this moment is in the shadow of something really important about how epidemics and the health of human societies are working. So I want to make sure, is everybody able to see the share? You're all able to see this?
Yes.
Very good. Let's be clear that human beings might be dominating planet Earth, but the fact is we share it with so many other creatures. When human beings destroy natural habitats, which is exactly what we've been doing as the progress of human population starts to spread over the course of planet Earth, when we're involved in spreading and changing the environment, adjusting it so that it meets our needs, we're reducing the level of biodiversity that exists on the planet. We share the planet with zillions of other organisms. And the notion that we are somehow on top of all this should not ignore, for all of us, the fact that we're about dominating, but we also have to share. The biggest problem with the destruction of natural habitats is that it often creates a kind of a selection pressure on all the organisms that are being threatened by human development. This often produces what's called the zoonotic spillover, which occurs when the jump of viruses, some of the most important and most significant components of pandemics, when viruses get to jump, as do bacteria, from animals to people. When we have healthy, diverse ecosystems, everything that allows this competition between organisms to proceed will create a kind of a balance. Nobody dominates, nobody gets completely wiped out. But the minute you start to get to a point where we're completely disrupting the environment, resilient, disease carrying species will start to transmit a variety of different infectious agents to human beings. That is the concern that we started to see with COVID-19. Let's be clear, the majority of diseases that have zoonotic origins really come from wildlife. Think about the ones that we've been struggling with over the course of the last 40 years. HIV/AIDS, Ebola, SARS, and COVID-19 are all basically zoonotic in their origins. We know, for example, that globally, we've been seeing more and more of these events where an organism passes from animals to human beings. And it's probably been the case that over the course of the last 80 years, as we have become more and more dominant with respect to how we are changing the environment of planet Earth, that dominance has indeed increased the pressures that ultimately create the kinds of organisms that might ultimately be at the core of pandemics. We left the World Health Organization in 2022 and 2026, January of 2026. What did this do? Well, the World Health Organization has always been responsible for maintaining a kind of a worldwide system of surveillance that allows us to know when an outbreak on one part of planet Earth is likely to pose a threat to other nations. Now that we're no longer funding and producing the kind of science that makes that sort of surveillance work, we are definitely at a significant disadvantage. Everything that is necessary to have worldwide coordination when you have a worldwide pandemic, to make sure that we have warning systems, the coordination of the development and the distribution of vaccines, everything that we have to do to create, as the slide suggests, a collective defense against emerging pathogens, does require, with so many nations on planet Earth, some form of coordination where the science, the development of policy, and the distribution of resources is somehow coordinated. Trying to do it nation by nation creates chaos, creates problems, and in too many instances creates a kind of a shortage of the flow of necessary resources to make sure that a unified and effective public health response can be put together. Let's be clear about how badly COVID-19 was managed. We lost more than 1 million people. Worldwide, we're number 17 with respect to how bad the pandemic was. And if you look at just the sheer numbers of deaths in addition to just the per capita rate, we rank number one. The slide makes it clear. This probably can be described as the deadliest disaster in the history of the United States. Folk might cite, well, you have about World War I and World War II. They did not kill millions. They killed tens of thousands. They were problematic. But the idea that what has ultimately been something that brought the nation to its knees was not armed conflict. It was a battle with Mother Nature, a battle with Mother Nature and the pathogens that surround us. The idea that that is probably going to mark a very important part of the 21st century is something that I think is really important to understand. But more than anything else, while I'm describing something that was worldwide in its scope, when you looked at how the pandemic actually expressed itself, the slide says it all. It was a neighborhood affair. Let's understand the importance of neighborhoods in the ways in which public health and the study of epidemics actually operates. It's a map of New York City. It's a map of New York City that looks at life expectancy at birth. How long do you live, depending on where you are born? Well, here's what this map points out. The ability to live a long and healthy life is not equally available to all New Yorkers. A baby born to a family that lives in the Upper East Side will live 11 years longer than a baby born to a family in Brownsville, Brooklyn. This inequity is unacceptable, but it is also at the core of why COVID-19 was not only deadly in the city of New York, it's why COVID-19 was deadly, particularly depending on where you lived and what access to healthcare was provided for you and your neighbors in your community. The comorbid conditions that were associated with COVID-19, which is to say, you got a COVID-19 infection, but if you were diabetic, if you were obese, if you were studying with cardiovascular disease, perhaps you were somebody who was struggling with hypertension, then the infection came on top of a pre-existing health condition that substantially increased the likelihood that you'd either be hospitalized or perhaps even die. The idea that those chronic disease conditions, obesity, diabetes, cardiovascular disease, and some forms of cancer, are very heavily targeted in segregated, poor communities of color, means that the history of the United States and the history of our urban development, going all the way back to the 1930s with redlining, produced a way of looking at communities in the United States, neighborhoods in the United States, where the greater the level of segregation, the greater the level of historical segregation, the greater the likelihood that when COVID-19 hit, those neighborhoods would suffer high rates of infection, hospitalization, and disease. What did we learn from COVID-19? The most important social determinant of your health is whether or not you lived in a community that, because of its segregation, limited your access to appropriate health care and limited your access to the resources that we know are so essential for maintaining a healthy and vibrant life. I have, for the last 16 years, been teaching in the Barred Prison Initiative. For 40 Mondays in a 52 Monday year, I'm teaching in a state prison where I've been engaging incarcerated individuals in degree work that is part of Bard College in upstate New York, where people can not only, while they are locked up, get a BA degree. Many of the folk who get that BA degree and who leave prison will have gotten it because they are taking concentrated courses in public health. I've been very successful, for example, over the 16 years I've been there, to have 15 men whom I taught in one of 6 state prisons upstate come to Columbia University and get graduate degrees in public health or in social work. But it's also been the case that since I've been doing this since 2010, I was present at the moment when COVID-19 hit the carceral system here in the United States. I'm going to bet that a lot of people aren't aware of the fact that during the worst of this pandemic, if you were someone who was locked up in a state prison, you were 3 times more likely to be infected with COVID-19 than was the case for mainstream America. And if you were unfortunate enough to get a COVID-19 infection, if you were incarcerated, you were 5 times more likely to die than was the case for somebody who was not locked up. Why did this happen? Why were prisons such problematic settings? Well, for a variety of reasons, they're congregate settings. This is from a state that has a zero tolerance policy towards crime. So politicians have said we need more cops, we need more courts, we need more cells in prison. And in way too many state prisons, what you're looking at is the absolute nightmare for the management of a pandemic where social distancing was essential. A lot of people who have not really spent much time making sense of the criminal legal system in the United States might have from television the notion that when you're locked up, you're in a cell by yourself. What could be better to protect you? What could be better for social distancing than to have your own cell? Well, as you can see in way too many facilities, you're looking at precisely why COVID-19 was so deadly for folk behind bars. Some of you might recall that Governor Cuomo wanted to prevent the distribution of vaccines to folk who were locked up in New York State prisons. It took the state Supreme Court to point out, dude, there's a 14th Amendment. You can't discriminate or limit access to a public resource based on a group that someone is a part of. So thankfully, folk got vaccinated. But the mortality rates, the morbidity rates from COVID-19 were nonetheless very, very tragic. Let's be clear about why thinking about COVID-19, thinking about pandemics, and thinking about prisons is something that in public health we have to pay attention to in the future. This is from the Journal of the American Medical Association. Reinhardt and Chen did a lot to study the impact of COVID-19 on carceral populations, and here's what they wrote. COVID-19 outbreaks in jails, prisons, and immigrant detention facilities do not only pose risks to incarcerated people, they also appear to spread to surrounding communities. This carries particularly pronounced consequences for Black and Latinx communities that are subjected to disproportionately high rates of arrest and incarceration, which may partially explain the disproportionate burden of COVID-19 that has been borne by racialized groups in the United States. The idea that as a nation, we hate crime. We are very much about commit a crime, we want you punished. The idea that we don't want our prisons to be places where people are coddled, we want them to really face up to the consequences of their crime. It really does represent something critical about our Judeo-Christian culture, but from a public health standpoint, what I've just described is the number one sin that you can possibly commit in the midst of an epidemiological crisis. And what is that sin? That never under any circumstance do you leave a reservoir of infection untreated. We don't like prisoners. We don't like prisons. The idea that we should invest in them because they might be centers of infection that in the next pandemic might be a source of infection for all of us is great science. But when we try to sell that to an American public that is already doubtful about whether or not public health has the answer to so many of the problems that our Americans are facing right now with their health, trying to sell folk on the notion that part of what we do to prevent the next pandemic from being so deadly is to engage in prison reform, good luck. But look at the science, look at the numbers, look at all the pieces that have been written that look at COVID-19, that have looked at COVID-19 in carceral settings, and you begin to see that what is something that Americans take for granted as a way of exerting social control over undesirable populations is also a set of strategies that in the end, should we be confronting another pandemic, it might just be the most important source of disease, of morbidity, mortality, and a national crisis one could possibly imagine. The idea that the Trump administration has systematically weakened public health has meant that measles has now come back to be something that is so problematic when it was almost completely eliminated. And it really does suggest that we are on a kind of a trajectory from a policy standpoint that will not only weaken public health in general, it's already become very, very clear that if we're not careful to survey all the ways in which modern life is increasingly exposing us to infectious diseases, we're not really prepared for what I see as a future that is already being announced with all of the food recalls that we've had to endure over the course of the summer. Our capacity to survey, to identify threats to the general public that come from our food supply only means that the next pandemic might be something that isn't going to be airborne. It could be something that's going to be a part of the food that we eat when our ability to make sure that that food is safe, secure, and promoting health is something that might just be beyond our means. So, if we can't count on federal resources to protect us from pandemics, I'm going to suggest that what we're left with is the idea that it's on us. Do you remember COVID-19 when there was a lot of confusion about where you go to get tested, where do you go to get vaccinated? That's the large number of people in New York City who died at home because they literally could not figure where to go and what to do. We can lay that at the feet of the Department of Health. But what I think is probably going to be more realistic in the future is to assume that we can't look to City Hall to be the place that will do the job of organizing us to really be ready for the challenges that another pandemic is likely to bring. In speaking to groups like all of you tonight, I know that there are some of you who are already heavily engaged in community organizing. You're very much about what's going on in your neighborhood. And if I can sort of add to the list the idea that that pandemic is coming, next 5, 6 years, we're going to see something else. We don't seem as a nation to have our federal resources doing the job to protect us. So maybe what's left is for us to figure out how we're going to protect ourselves. I'm always happy to sort of throw things out there and hope that in saying a few things here and there with some slides that are relatively simple, I've stirred enough interest so that we can have a conversation. What do you think? If it is all about what do we do ourselves to save ourselves, is that realistic? It's a nice way of ending a lecture, but is it really something that, as a nation, we're in a position to do? I'd love to hear from you. But that's it for me. Your turn.
Me,
I unmuted and then I lost him.
it's all good. We can hear you,
Yeah,
Miriam.
Okay, thank you. That was quite a lecture, and quite a reckoning, actually.
that's what you
Um,
wanted, right?
and I keep losing you, but I'm trying. Um, well, the floor is open. I mean, you've invited people
Yeah.
to respond, and so respond, people. After you get that glass of water and say, "Oh my God."
I saw that
Um,
Diane had her hand raised. So you can unmute yourself, Diane.
I'm sorry, that was an accident.
Okay, moving on. Rebecca Laurie has her hand raised. So, Rebecca, you can unmute yourself.
I was just going to jump in without raising my hand, Diane. When I saw you had manners, I was like, okay, me too. Thank you, doctor. That was great. Oh my gosh, I'm loving this. So I get privileged to teach urban studies at the School of Labor and Urban Studies at CUNY, and I'm putting together a class this semester on community development. And I'm using a book by Nicholas Freudenberg that just came out called Fighting for New York. Activism.
Nick,
Yep.
Columbia DRPH graduate, the big guy
Ac-
at the School of Public Health for the City University.
Yep.
And am I right? You have a lot of my BPI students.
Yes. Yes.
So glad to meet you.
I'm glad to meet you too. I've known of your work, Muriel. I'm so grateful that you brought Dr. Fullilove here today. And so much that you say. So my life's work has become raised by a community organizer in the same era that you and Muriel went down to Mississippi. I was a little younger, but certainly of the generation influenced by civil rights, and then life goes on and we learn more and more as this all goes on. So I got very involved what I refer to as the solidarity economy, often thinking we have to we have to build the next system as we go. And that to me is so much about community engagement. I was really happy you were saying we can't just rely on City Hall, nice this season, but we also have to build our own systems. And so really I'd love to hear more from you about what are some of the elements of community engagement that will help us have the system we need through the multiple crises we face
Very good.
without hang on. Yeah.
I have been very impressed with the creation and training of community health workers. I am the co-director of the Columbia Center for Community Health. And for the last 10 years, we've had a program called In Touch, which takes folk from, I'm going to use its origin as the way of sort of describing it, from churches and faith communities in the city of New York, and trains them on a wide variety of things having to do with the health of the public. These are folk who are very useful in assisting folk when they're trying to control their hypertension, to make choices around medication, exercise, what have you. The most important thing is we are in a moment in the United States when the medical system is falling apart. COVID-19 arrived at a moment when we had a very aging health force of nurses and doctors. They are two of the professions that have the oldest group of members and the folk who are most likely to retire. It takes 20 years to train a doctor. And although you can train nurses in a slightly faster fashion, it becomes clear that COVID-19 did such an important job in the ranks of people who are engaged in healthcare that we got to think about how do we rapidly repair all the holes that were ripped in the system, went through retiring or through death as a result of exposure, lost a lot of people. Well, the idea that in a 6-month period, you can train a community health worker to be someone who assists people with diabetes, cardiovascular disease, managing the problems that are related to, let's say, a pregnancy, helping people who are in recovery from substance abuse disorders to stay stable. Many people who are still working with those who are HIV are community health workers who help folk with maintaining an appropriate schedule for the taking of medication and doing all the other things that are going to keep them healthy. What I'm describing is a way of organizing folk in the community to become the bridge between clinical care on the one hand and members of the community on the other. A lot of the folk that I trained and that BPI trained during the pandemic, who started to work for the Department of Health and Mental Hygiene here in the city, and who were instrumental in helping people who were on the fence about whether or not to get a COVID-19. That's where we saw that folk who are trained to work in the community, but who also have training in medicine and public health, can be the trusted members of the community who decided that, yeah, I'll take COVID-19, not because the science convinced me. I'm taking COVID-19 vaccines because somebody I trust suggested that this was okay. Again, at a moment, you'll recall at the beginning of my talk, where the general public is very suspicious about public health in general, they're about to throw Anthony Fauci in jail. It's so typical of the United States, right? Instead of looking for cause and effect and ways of dealing with a crisis, we're all about who was to blame. We think somehow or other, if we identify the culprit, things will get better. But in fact, what we really need to do is fill a void that has been created by the last couple of years of public health crises. And I'm going to suggest that training people in the community to be the bridge between community members on the one hand and the folk in the clinical care settings on the other is the way to go. It worked with COVID-19. It dramatically boosted rates of vaccination acceptance in communities that were very hesitant to do that. And I think it is the wave of the future. And it's something that in a program that does the kind of training that you're involved with becomes an easy addition to what we provide folk who want to do community work. So that they're not only in the community, they're doing it in a way that's going to maximize their effectiveness, as well as the participation of folk in the community. So I keep thinking that investing more in that kind of creation of a workforce that's going to be uniquely suited to the changing ways in which health is evolving in the United States, that's the answer that we've really got to seek. And those of us who do training and education, I think, are in a unique position to find ways to make sure that that happens, to make sure that it's effective, to make sure that when it's put in the field, we're assessing and evaluating it appropriately so that we can improve the impact that it's likely to have. I keep thinking that these are plans that are relatively easy to put in motion. They don't require federal funding. They can happen level. There are already examples of our doing this. And if we look at nations like India and China, which have had barefoot doctors, these kinds of community health workers, we can see that the impact that they've had on the health of folk in those highly dense population settings has not only been really quite remarkable, it's something that's worth emulating.